reduces the bioceramic all the way to the end of the tooth. We're going to then place the hand file back into the disinfectant, and then we're going to just very, very gently push that GP cone to length. And again, I do like to say you're never going to ram this home. So, hello, welcome today. This is this week's Friday clinical case. This is a case where we found essentially 5 separate orifices. In today's case, we are going to negotiate these 5 orifices and see if they are separate canals, they've got their own portals of exit, or indeed do they join together. So these types of cases are really, really interesting because, if you do a lot of root canals, you are doing the same teeth over and over and over again. And sometimes it's just nice to have a little bit of variation. So, I suppose if you're a general dentist, and you are treating molars, you just want to find the easy things. But again, if you're doing a lot of molars, when you open up the canal space, you open up the access cavity, and you find 5 orifices, well, you're in for a treat, I think. So it makes the treatment just more interesting. And of course, you tell the patient afterwards, and they're nonplussed and they're not interested. But I suppose these sorts of exciting cases make you go to work. So before we get into the case, however, what I do want to say is, I look at the analytics of the channel, the YouTube channel, and I noticed that the vast majority, up to 2/3 of the people watching these videos, are not subscribers. So if I could ask you just a really, really simple and free favour, and that's just to hit that subscribe button. Hitting that subscribe button really, really promotes the channel with the algorithm with YouTube. It also spurs me along, and if you hit that subscribe button, I promise that each video, each week, will get better and better. So let's look at the case. This is of a lower right 6. The patient was an external referral again, and in this case, the patient had not seen a dentist for a while, and they were having symptoms from this tooth, and they saw their regular dentist, and they were having symptoms from this tooth. And of course, when we look at the periapical radiograph, we can see this decay in the distal aspect of this tooth, and you don't have to be qualified long to work out that this tooth is obviously, the pulp is exposed. So in the first instance, what we don't have the video of is me shoring up the tooth. So what we do is, I like to do a cheeky 30-minute appointment before we go ahead with any root canals, and we just pull all the decay out, all the temporary fills, and we shore up the tooth. So we put a proper composite filling in this tooth, and this obviously serves 2 purposes, because if you are booking a root canal straight in for a 2-hour and you find out the tooth isn't restorable, well, then it's not very cost effective for you, and it's not great for the practice, and it's just a bit annoying. So it's always important to know, if you're not unsure if a tooth is savable or not, just to get them in for a 30-minute appointment, do a filling, and then shore it up. And of course, when we lead into the video, this is at the point where the second appointment. So I've shored up the tooth with composite filling, and I've placed non-septum calcium hydroxide in the cavity space, PTFE, and then GI on top. And I do like using PTFE, but what I would say is, like cotton wool, sometimes if you don't remove the whole of the filling, it can be quite tricky to remove. And it's obviously like quite a ribbon-shaped string sort of thing, the PTFE. So sometimes when you're pulling it out like it's, you're taking hankies out of a like a magician, if that cultural reference relates to anyone at all. But as soon as we open up the tooth, we can see there's vital tissue, and I'm really, really concerned about this hurting the tooth. Of course, the patient's been numbed up. I use an ID block and a buccal and a lingual infiltration. But when I get my ultrasonic on this tooth and I put the ultrasonic on this vital tissue, the patient, you can see here, kind of recoils, and the patient is obviously not numb. So what's really, really important is we don't carry on. In this case, what I did is I'm really, really early on in the root canal appointment, so I'm not too fussed about removing the rubber dam, just to give that extra buccal infiltration there with the articaine. So we're going to avoid the distal aspect of this tooth now, because we know that that's vital and a bit sore. So we're going to make sure the LA really soaks in there and works. So we're going to go down the mesiolingual in this case, and I'm using a size 10 K file. And sometimes, because if access is difficult, I like to use the K file on a pair of tweezers. And notice with the K file that the negotiation is quite difficult. So what I want to do here is I'm getting a size 10 high flex glide path file, and I'm just open up the coronal third. I'm not going too far because I don't want to ledge the canal, of course. And in this case, I am using a higher diameter file, not an orifice opener in this case, because it's more cost effective for me to use the master apical file. This is a 25 high flex variable taper, and I'm just opening up that canal space. And usually what happens is when we open up the coronal third, the size 10K file now negotiates quite nicely to length. So, and I've noticed here that the rubber stopper's kind of in the wrong position, so I'm just using a pair of tweezers just to adjust that, because sometimes when you're negotiating, this rubber stopper can get in the way. And again, you know, I'm getting to the point where I think maybe I'm at zero. Comes with experience, I'm afraid. I'm just going to hook the file up to the apex locator, and we're just about at the apex. And again, you'll know with a lot of my videos I like to push the hand file out the end of the apex so we go past zero, and then we're going to back it up, and I think that gives us the best and most accurate working length. And of course I'm using a size 10K file. Some would say a size 15 would be better for a more accurate apex locator reading, but in this case I'm happy. We remove the hand file, we measure it, and the working length of the mesiolingual is 19 millimeters. So once we found zero, I am going to use a size 10 high flex glide path file to zero. We're going to push that to length, lots of irrigation, and we're just going to complete the shaping. In this case, because I got to the apex quite easily, the step up from 10 to a 25 to final shaping wasn't too difficult. But what's really, really important here, as you can see, I'm recapitulating, and what I'm doing is I'm going to get in a size 10K file, and I'm pushing it to zero. And what this does is it just sort of agitates the debris and make sure that the canal space actually is open, ready for our obturation at a later date. So the mesiolingual's finished. We're on our way. We're going to now negotiate down the mesibuccal canal. And in this case, what I do notice is when I sort of use a sort of watch winding motion with my size 10K file, again, the negotiation isn't too great. It's not rushing down to the apex. So again, it's the same protocol as before, using a size 10 high flex to open up the coronal mid third. And then when I place the size 10K file again in the mesibuccal, we're going to hook this up, and then this negotiates quite nicely. And again, it's the same thing. We're going to push the size 10 out the end and bring it back. And you'll notice here that the negotiation is just a little bit tougher than the mesiolingual. And again, when you reach zero, you just adjust the stopper. When we pull the size 10K file out, we measure it, and we know that the mesibuccal canal, the working length is 18 millimeters. And once we've found zero, we're going to shape the same protocol. Okay, so the mesibuccal and the mesiolingual canals are pretty straightforward. Although what I would say is the glide path file in this case doesn't negotiate as quickly as it does in mesiolingual. But despite the fact that mesibuccal, the glide path file isn't reaching down the mesibuccal quite quickly, I think it's reaching enough that I can step up nicely up to a size 25 high flex. It's kind of at this point where I'm thinking to myself, maybe there is a middle mesial. And what I mean by a middle mesial, this is a canal which is found in between the mesilingual and the mesibuccal. And if you're an endodontist or you're a general dentist who does a lot of root canal, finding a middle mesial is like heaven. So this is exciting for me. And in the first instance, what I'm going to do is I am going to place a size 10K file or negotiate the possible orifice. And when I place a size 10K file into the potential orifice, I notice that this sticks up in the air, so we know we're in. So at this point, again, I'm thinking to myself, Is this middle mesial got its own canal space? Does it join? Does it join with the mesiobuccal? Does it join with the mesiolingual? So what I'm going to do is I am just going to open up the coronal to mid-third, both with ham files, also with my glide path file. I suppose in my case, I think these glide path files are nice and safe as long as you don't push them too far. You just want to make them cut their own sort of path. And again, I'm just checking for confluence here. And when I irrigate and aspirate with my syringe, I notice that the irrigation aspiration doesn't occur at the same time. And what I do is I suspect that the middle mesial's got its own canal space. So I am going to do the same shaping protocol. And actually, when we do the final shaping in this tooth, you can see that obviously the middle mesial joins with the mesiobuccal, which is disappointing because you want to do nice cases and interesting cases. But in the end, what's really, really important is despite that this middle mesial joined quite coronally in the tooth, you've obviously cleaned some canal space. And imagine if you hadn't cleaned that, well, maybe you might have left some bacteria in there which could have caused failure. So the next canal I'm going to negotiate down is the distolingual. We know that the distobuccal was vital and painful, so again I'm just going to do that one last. So we're now ready to negotiate down the distolingual. We know that the distobuccal is vital and painful, so again I'm just going to do that right at the end. And again, the distolingual, like the mesiolingual and mesiobuccal canals, are quite difficult to negotiate. But, a little bit of watch winding with size 10K file, I am progressing nicely to the apex. And you can see here again with the apex locator, we're a bit far away, and it takes that kind of extra little bit of care just to get to the apex. And again, we get nicely. It's all about taking your time. You don't want to race too far down to the apex because you're going to cause iatrogenic damage. And then when we reach zero, we pull the hand file out and we measure that the distolingual is at 18 millimeters again. And we're going to do our initial shaping with this size 10 glide path file. And in this case, what I feel like I'm going to do here is that going from a size 10 glide path file up to a 25 might be too big a jump. So I'm going to do like an intermediary file. But first of all, we're going to recapitulate again. Remember, we were talking about recapitulation. We're going to take our original ham file. We're going to push it to length. I'm going to make sure we agitate that debris and lots of irrigation. And in this case, our intermediary file is a size 20 high flex. And what this does is it kind of opens up the canal space ready for the 25 to negotiate nicely. And what you'll notice, again, I'm doing lots and lots of recapitulation. So, I might not recapitulate with all canals and all teeth, but if I'm a little bit concerned about the sclerosis or the calcified nature of the canal, I'm going to just keep recapitulating. And you might think to yourself, well, this is just an extra step and I'm in a bit of a rush and I've only got this certain amount of time to do a root canal. But it's really, really, really important just to make considered and a judicial kind of. And it's really, really important just to make these kind of really patient decisions. You don't want to rush down there because if you cause a ledge or you cause a blockage, that's going to take you longer to sort out. And of course, it's not in the patient's interest. And again, we've shaped with the 20 and the 25 high flex. Now it just pushes to length really, really nice and easy. And again, lots and lots of irrigation and recapitulation. So the distolingual's done. That's all boxed off. So we've technically shaped and negotiated 4 orifices, and now we're ready for the final canal. This is obviously the DB, the original vital canal, which was saw. We'll negotiate the size 10K file down there, and I'm being really, really careful because I really don't want to hurt the patient. It might sound blindingly obvious, but unless you're a psychopath, causing pain to patients is not what a dentist wants to do. I can tell you that for now. And so there's that kind of aspect to hurting patients, but there's another aspect. If you hurt a patient and you're a referring dentist and they go back to your dentist and go, Christ, that guy was awful and he'd hurt me, they're less likely to refer to you again. Again, it might sound blindly obvious, but not hurting patients is always in your best interest. And I think, you hear stories of some dentists that say, oh, just get on with it. But I think you should be treated the way you'd want to be treated. And I think if you were a bit scared, you were having root canal and it was sore, you'd want the dentist to stop for sure. So, sometimes we've attempted root canals on patients where they haven't been managed to be numb. And in the end, that's just the way it is, because you're never going to do a root canal on a patient if they're in pain. You'll never do a good one because they'll just be squirming all over the place. But again, not to mention, it's just not a nice thing to do. Another thing I've noticed with Canal is this is probably the most difficult one to negotiate. So this is the most difficult one for the ham files to reach 0. And I actually feel like this is more sclerosed and calcified than normal. So I'm going to change tack a little bit with this particular Canal. I'm going to open up the coronal third with our glide path file, lots and lots of irrigation, but this time I'm going to get a definder. This is a shorter length definder, so it's less flexible. So when you're pushing down on the ham file, it's less likely to flex and more likely to get to length. And again, I'm just making a little bend at the end with this definder and just slowly negotiating down. And the great thing about these definders is, for some reason, they just reach 0. They look they work fantastically. And we're just going to hook the definder up to the apex locator. You can see we're miles through, so not the end of the world. Again, we're just going to bring the file backwards. And then we're going to get our 0 reading. And sometimes, like I say, I like to push it through and back again. Once we've reached 0, we're going to just adjust the rubber stopper, take the ham file out, and when we measure the ham file, it's the 0 reading is found to be 17.5 millimeters. And I told you I was going to change tack with this particular Canal. Again, we're going to use this size 10 high flex glide path file, but in this case, I'm going to use it in T mode. T mode is on my black AI motor. It is a reciprocation mode. It does the same motion as I am doing with my ham files, which is watch winding. And once I sort of reach to an acceptable level with my watch winding T motion, I press another button, and then this turns into rotary, and this kind of opens up the canal space. This mode is also fantastic for ledgers. And we're going to use the mother-in-law rule here. We're going to just quick kiss in and out. We're going to just push the glide path file to length and back out. And again, remember, recapitulation is really, really important. So in this case, again, we're going to push the definder to 0. And sometimes it can be a bit difficult, especially if it's the patients that open it nice and wide and just in and out. And just going to make sure that the canal space is still patent. And again, we're going to go up with the 20 rather than 25. And in this case, I don't think T mode is required, because I know that I've shaped it quite nicely with a glide path file. And you can see here that once the glide path file is cut your glide path using the size 20s and using the size 25s, it just works really, really nicely. And essentially that is all of the canal spaces shaped nicely and ready for our obturation. And my nurse is just preempting the obturation, and she's setting up some of the GP cones into my GP cone disinfecting ring. Again, you've seen a lot of my videos. I like to use this ring as a kind of a focus point for all our consumables and our equipment. And I am just going to get a GP cone. We're going to just inspect the end of these GP cones, because sometimes they don't look great. We're going to measure the GP cone, and we're going to just push it really, really nicely to length. And obviously when you push it to length, you're going to pull the GP cone back slightly and feel for that tug back. And then I like to just snip the cones off and the excess. And again, I personally like to do this. I'm not too sure if other people do like to do this. I know my other friend doesn't. It's again, I've said this many times. If this GP cone, the end is kind of sticking out, and then when you take the cone fit radiograph and the dam sort of moves around, it can kind of push these GP cones out. And then when we look at the cone fit radiograph, you can see here clearly that there are 4 separate canal spaces, which looks absolutely fantastic. especially on the distal aspect here, because a lot of the time what you find with lower molars, the distal distal root has two orifices, but usually they join. So this is a really, really kind of nice looking thing, and weirdly enough, I do take teeth out, and I very, very rarely see these sort of double distals, and I wonder if this is a sort of figure of eight type of shaped root, or are these two separate roots? And I think our oral surgery colleagues would probably say this is kind of like a if not, it's a very large and wide single root. It might have a kind of a figure of eight kind of configuration. What I would say is when the cone fit radiograph is getting developed by the nurse, I like to set up the correct irrigants, and it just helps with efficiency. And what I'm doing is I am pouring sodium hypochlorite into the correct wells, and you'll notice here that each well has its own canal designation, and we're going to use EDTA in a separate extra well. And I've started to use isopropyl alcohol to dip my GP cones in as I'm about to obturate. What's a really, really important thing to do is to disinfect your GP cones. So you can see here on the on the image on the left, you can see I've pulled out the distolingual GP cone, and I've placed it into the distolingual well. These disinfecting rings are absolutely fantastic because, before I had this, I used to lay the GP cones on the side, which is absolutely mental. I can't believe you used to do that, because obviously the bacteria in the surgery, this was when I was super early qualified, and also sometimes I used to forget which GP cone went in each canal. So this is just a fantastic organizer. And we're now ready to do our irrigation protocol. The first irrigation step is to use sodium hypochlorite. And in this case, I'm using the Irriflex tip to put this hypochlorite into the canal spaces. We're then going to activate it with a very specific ultrasonic irrigant activator, and we're just going to do that over and over and over again. And you can't do it enough, because the most important thing here is to make sure the bacteria is being killed, because that's what causes root canal failure. We're then ready to irrigate with EDTA. So I'm going to use the same syringe, the same tip for cost effectiveness, and then I'm going to suck up the EDTA which was placed in our disinfecting ring. And again, it's the same sort of thing. We're going to irrigate with EDTA down all of the canals, and what this does is it removes the smear layer that's been created by your rotary files. And then we're going to activate the irrigants, and we're going to do that many times. We're going to make sure that those dental linal tubules are really nice and open. Final irrigation step is going to be sodium hypochlorite. And what I like to do is to take the sodium hypochlorite from those GP disinfectant wells. And again, this is more cost effective, and it's also quite efficient. You can just suck them up nice and easy. But the nurse doesn't have to sort of go to the bottle and get in there and draw some more out. And the great thing about the EDTA is open up all those dentinal tubules, which now the sodium hypochlorite can flow and kill all that bacteria. And then we're ready to dry with our paper points. Again, I like to put the paper points in this sort of drying area, and make sure that the canals are really nice and dry. So we're ready for our obturation. I like to get everything set up. We get our heated plugger, we get our bioceramic sealer with the tip on the end, and then what I do is I pick up the GP cone, I dip it into some isopropyl alcohol, I then air dry this, and then I put that GP to the side. I'm going to use a brand new hand file. I'm going to disinfect that, and then I am ready to go. So I'm going to get my bioceramic sealer. I'm going to use this visco tip here, and I am going to fill the coronal to mid-third of the canal space with my bioceramic sealer. And just, injecting directly into the canal space, you need high magnification essentially. So you're ready to go. Everything's out. We just pick up our hand file. We're then going to negotiate the hand file. I usually do it about 2 to 1 millimeters away from the zero reading. And what this does is it sort of introduces the bioceramic all the way to the end of the tooth. We're going to then place the ham file back into the disinfectant, and then we're going to just very, very gently push that GP cone to length. And again, I do like to say you're never going to ram this home, because if you ram it home, well, if you push it really, really hard, you're going to have more extrusion, and sometimes you're going to have that kind of bobbing effect where the cone is getting stuck, and the sealer can't sort of escape around the outside, vapor lock essentially. And then we're just going to cut the excess off with our heated plugger, and then we're going to use these Mach 2 pluggers just to condense down. I don't use the heated plugger to condense down the GP cone because I am quite forceful with my condensation, or my compaction, that's probably a better word, and if you do that with the heated plugger, you're going to break the end because they're quite malleable. And then we're ready to do our other canals, the same sort of protocol. We're going to take the GP cone out of the disinfectant, we're going to dip it in isopropyl alcohol, we're going to blow dry it, and then we're going to put it to one side, because it's important to be ready when you place the sealer, that you can just pick up the GP cone straight away. Sometimes I've noticed that if I put the bioceramic in the canal space, but the GP cone isn't ready, and I'm mucking around, or say I drop the GP cone, like again I got another one. Over a very long period of time, what can happen is that this bioceramic concealer can lose its kind of flowiness, if that's a word, and sometimes you can't push the GP cone to length. And overall, we look at the radiograph, and it looks really, really, really nice. You know, the untrained eye might say that one of the GP cones in the distal aspect here has been extruded or overextended out the end. I personally think this is sealer. I've seen a lot of this radiographic presentation, and when I do my post-op radiographs in a year's time, you'll notice that this has disappeared because the bioceramic sealer has overall resorbed. And that is the case. Thanks for watching all the way through. Again, like I said before, one of the best ways to support the channel is to hit that like button and subscribe. If you really, really like the channel, we've got a membership program. The membership program is a small monthly fee, and it just supports the channel, keeps me independent, and also you get early access to content. And I'm usually running about 2 to 3 weeks ahead. So if you really like the videos, you can't get enough of them, join as a member, and you can see these videos much, much more in advance. And I'd like to thank you for watching, and I will see you next week in the next video. Bye-bye.